Hi, my name is Lori Stevens, and I'm going to be talking to you about why it is important for hospitals to invest in a family disclosure training program or process within their institution. Oftentimes this area is overlooked, and if disclosure is done improperly or incorrectly, it could have a negative and expensive impact on the institution. Not only is the clinician-patient and or family relationship damaged, but in most cases it cannot be repaired. Most of the direction in most of these circumstances comes from staff in the risk and legal department to provide initial support and direction to the clinician when disclosure is appropriate. And while this is proper protocol, most clinicians feel very ill prepared to effectively disclose to a patient or family when something happens. The results of not having an effective family disclosure training program are financially significant due to high litigation costs. The patient and family experience is also threatened, resulting in poor clinician-patient relationships and ultimately affecting the future care of that particular patient. There's also an effect on the clinician staff with regard to morale. Turnover is also a direct result of having poor training available to staff when something goes wrong and they have to disclose. Let me provide for you a scenario. The attending physician or clinician has realized that something has horribly gone wrong with the treatment of a patient. The rest of the attending team is called to correct the situation as well as stabilize the patient. The patient is now stable. The team assesses the harm caused by the error and realizes that there is a high degree of confidence that this harm could be permanent. Only time will tell. The next step is to tell the family what happened. The attending clinicians begin to ask themselves, what do I do? What do I say? What if they don't trust me anymore? What if I lose my job? And then ultimately they realize, I'm not ready for this. You know, research suggests that clinicians are not adequately prepared to have an effective disclosure conversation with the family after something happens. And they've not been properly trained specifically in this area, nor have they received the coaching necessary to improve their performance in this particular area. During this presentation, I'm going to make two main points. The first, clinicians don't feel prepared to effectively disclose to a family and desire training in this particular area. Point number two, simulation training is the most effective way to train in one of the key components in an effective and maintaining an effective family disclosure program or process. Let me expound on my first point. Clinicians don't feel prepared to effectively disclose to a family and desire training in this specific area. Let me call your attention to the chart behind me. This chart is clinicians' level of agreement with statements regarding communication or communicating with patients. This chart is research and data shown. This chart shows research and data provided by Brown, Callahan, Browning, Lebowitz, Bell, Jay, as well as Meyer, and this study was done in 2014. There are two primary things I want to focus on. The first, the clinicians or trainees were asked, I am comfortable communicating with patients about new, unexpected, or quote, bad news, end quote, that I diagnose. The data here is based on a pre-session or pre-training as well as post-training. You'll notice that in pre-training, 44% of the trainees agreed with that statement, while 55% disagreed with that statement. After training, 73%, a little over 73% agreed with that statement, while only 26.9% disagreed with that statement. The next question. I would like more training on medical error disclosure. 78.9% agreed with that statement prior to going to training, while only 20.2% disagreed with that statement. After training, 83.3% agreed with that statement, while 15.7% disagreed with that statement. So as you can see, according to this chart, the data shows that overall, clinicians desire training in this particular area. And while most clinicians have had other limited training during their residency, practicum experience, or even via continuing education, most agreed in this particular area, and as this scenario has already pointed out, that more specific training is desired. As a result of medical errors coupled with the inability to disclose properly to a patient or family, a clinician may ultimately quit or leave the profession altogether. According to Brown, Callahan, Browning, Lebowitz, Bell, Jang, and Meyer in 2014, even veteran physicians experience substantial stress communicating with patients about unexpected or difficult diagnoses. When errors occur, stress may be compounded by patient anger as well as physician shame and anxiety. My second point, related to simulation training, is most effective way to train or coach clinicians and one of the key components to maintaining an effective family disclosure program or process. Brown, Callahan, Browning, Lebowitz, Bell, Jang, Meyer indicate that evidence suggests that traditional didactic models for teaching communication to physicians are insufficient to meet this complex demand. This was back in 2014. However, new communication training programs that cover general medicine, pediatric, and surgery now combine didactic methods with simulation, role play, group discussion, and video presentations. Other studies, such as the one conducted by Raper, Risnick, and Morris in 2014, reference filming clinicians in a simulation center, disclosing on a scenario to a standardized patient, or in other words, we will call that person an SP. The scenarios were then videotaped and reviewed by faculty, as well as the SP, and scored using a 5-point Likert scale over many different domains. Clinicians then receive individualized coaching and feedback to help them improve in this particular area. In conclusion, I like to state that proper training and ongoing coaching are necessary components to improve a clinician's ability to have an effective disclosure conversation with a patient and or family when something happens. A summary of my main points. Clinicians aren't prepared to have this type of conversation, which can have a long-lasting negative impact. My second point, evidence has shown that the best way to prepare clinicians is by providing a combination of simulation and didactic training with proper coaching and feedback loops. In closing, there's a huge learning curve when it comes to disclosing to patients and families when something goes wrong. Patients expect and want timely and full disclosure of the event, an acknowledgement of responsibility, an understanding of what happened, expressions of sympathy, and a discussion of what is being done to prevent reoccurrence. Patients are more likely to sue if they perceive that an honest disclosure of an event was absent, according to the committee opinion in 2012. Hospitals and medical centers should work to close this education gap so they are able to maintain positive clinician-patient relationships and interactions, build and continue with the trust involved, and ultimately prevent litigation expenses. Thank you.